Hi, this is Stephen-Castro, and I'm going to do a quick presentation on the assessment of the abdomen, bladder, and kidneys. Please review the structures and organs of the abdomen. Pay attention to the liver, the gastric bubble or the stomach, where the spleen is, as well as the loops of bowel. As with all assessments, we need to begin with a history. This will include any past and present conditions or surgeries, any pain they might be having, their normal bowel habits, any bladder difficulties, their nutritional status, if they smoke, and any medications that they may take. Prior to performing your abdominal assessment, here's a list of things that you'll need to do with your client before proceeding. Review the 4 quadrants of the abdomen as well as the different areas, the epigastric, umbilical, hypogastric, or suprapubic area. You will be responsible for these when you do your assessment as well as on your exams. One more review of the organs. Again, pay attention to where the liver is, the stomach, especially the gastric bubble region, the spleen, as well as the loops of bowel and the pancreas. As I've mentioned before, the steps of the abdominal assessment are a little different than your other assessments. We always begin with inspection, but with the abdomen, we then go to auscultation, followed by percussion and palpation. Do you remember why? When inspecting the abdomen, stand to the right side of the client if possible. We want to observe from the side and from above the rib cage, all the way down to the pubis. We're looking for symmetry and contour, the skin integrity, the hair distribution, any peristalsis, and of course, aortic pulsations. Inspect the skin for color. It should be uniform with the rest of the body. Occasionally, you might see something like tan lines. You would want to watch for anything abnormal, such as jaundice, which is the yellowing of the skin, cyanosis, or if it's glistening or taut. Notice any other skin variations, including striae, also known as stretch marks. You also want to look for any redness, any ecchymosis, or bruising. And there's 2 things called a Cullen sign and Grace-Turner sign that may show a retroperitoneal bleed. Pay close attention to that. Continuing on with your inspection, you'd notice any rashes, any scars, or nodules. The scars on this picture show some common scars from some common surgeries, such as gallbladder, appendicitis, and others. Now you will assess for the contour. The contour is the basic shape of the abdomen. Is it flat or round? Scaphoid is where it's sunk in, or protuberant or distended protuberant is when it sticks out quite a bit. Now we're inspecting for symmetry to check to see if the abdomen is symmetrical. We're also going to check for any type of distension. If the abdomen is in fact distended, you may need to take measurements. This is common with liver patients. Please make note of the umbilicus as well, whether it's central, inverted, or protruding. Continue your inspection for any bulges and swelling. Some bulges may include hernias, tumors. There also may be some distension at the gastric region. Any tumors in the lower distension may be ovarian issues, or even pregnancy, fibroids, or even a full bladder. While inspecting the abdomen, you may visualize hernias. Here are some frequent sites of hernias. Pay attention to the umbilicus area, the epigastric area, as well as the incisional area. The other frequent area is the femoral or inguinal hernias. We use this mnemonic, the 6 F's, for abdominal distension. Most common reasons for a distension are because of fat, because of feces, because of fluid, because of a fetus, fibroids, or flatus, otherwise known as gas. Continuing with your abdominal inspection, you're going to look at motility or motions, looking for respiratory effort with the abdominal muscles, peristaltic waves, which you may see from digestion, or pulsations. Bounding pulsations may be problematic. Now on to auscultation of the abdomen. Try to warm the diaphragm prior to putting it on your client's skin. Start clockwise in that right lower quadrant. Listen to all 4 quadrants for any type of bowel motility or vascular sounds. It's normal to hear 5 to 35 clicks or gurgles per minute when listening to bowel sounds. The term is called borborygmy, and that's called stomach growling. Hypoactive is less than 5 per minute. Hyperactive is greater than 35 per minute. Absent is no sounds for 5 minutes. This may be difficult for you to hear at this point in your training, but you may hear some vascular sounds. There are some rubs from the hepatic and splenic arteries that you can listen to with your diaphragm, as noted on the picture, as well as some potential bruits, which should be listened to with the bell, as well as any venous hums. Moving on to the percussion of the abdomen, your percussion will help you assess the size and shape of the organs depending on what sound is elicited. It'll also help identify fluid, air, and solid masses. Tympany is what normally you should hear throughout the abdomen. You may hear accentuated tympany at the gastric bubble. When percussing the abdomen, it's important to use a systematic method. These methods will cover all 4 quadrants of the abdomen and address all organs and the gastric bubble. Either one of these methods would be sufficient for your exam. Here are the locations of some organs that you may be able to elicit on your percussion, as well as where the gastric bubble is. Blue indicates the organs, and the red indicates that gastric bubble. Here is a slide that shows you how to percuss the liver. This is not something that you would do normally on a normal head-to-toe assessment, but it would be more of a focused assessment for someone who might be suspected of having some liver problems. But please note the landmarks. Similarly, this is a slide that shows you the technique on how to percuss a spleen. Again, normally this is not something done on a normal everyday head-to-toe assessment, but more done with a focus assessment when you suspect there might be an issue. To percuss the bladder, you would start just above the umbilicus and go down towards the pubic area. The sound should change from tympany to dullness. A full bladder will be percussed as dull. If you're unable to percuss the bladder, it may have less than 150 milliliters of urine in it. Some of those in more advanced practice may percuss the kidneys. This is done by finding the landmarks over the costovertebral angle and applying some direct percussion. You may see physicians or other providers do this. This is very important. Make sure you do not palpate the abdomen. If they had a bounding aortic pulse when you were doing your inspection, on your auscultation, if you heard an aortic bruit, which is the swishing sound, either one of those might indicate that there is an aneurysm or history of a transplant. Palpation of the abdomen is important to assess the abdominal organs. It assesses the size, the shape, mobility, and consistency. Also, we will assess for pain with palpation. If they do have some areas of tenderness or pain, make sure you avoid that and do not proceed with deep palpation. You will begin with light palpation in all 4 quadrants. Use one hand, let the client get used to your touch, and do not depress any more than 1 centimeter. Try to be smooth and consistent with your depressions. Watch for any pain or guarding when you're doing your palpation. After you've completed light palpation, you move on to moderate palpation. Again, you'll do this in all 4 quadrants, a little bit deeper, between 2 to 3 centimeters. Use both hands and continue to assess for tenderness. If the client was able to tolerate light and medium palpation, you may want to proceed to deep palpation if you need to do a focused abdominal assessment. Typically, on your normal head-to-toe assessment, deep palpation isn't necessary. If you do proceed to do deep palpation with your client, it helps delineate and assess the organs and other tumors, masses, and those things a little better. But again, this is not something you would typically do on a normal head-to-toe assessment. Although not part of a normal head-to-toe assessment, you may want to do a more focused assessment, and this might include palpation of the aorta. If you do want to palpate the aortic pulse may be palpated just above and to the left of the belly button or the umbilicus. To palpate the liver, the most common method is the bimanual method. You place your left hand under the bottom of the rib cage on the posterior side of the patient, and with your right hand, you palpate up under the rib cage, as shown in the picture. Another technique which may be helpful with obese clients is the hook method. You place your fingers at the edge of liver dullness when you percuss, and as the client takes a deep breath, you slowly move your fingers up to feel for the liver edge. The spleen should not be palpable in normal conditions. Occasionally, if they are concerned that there might be splenic enlargement, they may do a more in-depth exam and try to palpate the spleen. Please refer to your book for this procedure. Bladder palpation is not a part of your normal head-to-toe assessment. On occasion, it might be necessary to palpate the bladder if your client has certain conditions such as urinary retention. Normally, a bladder with less than 150 milliliters of urine will not be palpable. Next, you will palpate and inspect the inguinal area. You're going to palpate the femoral arteries bilaterally and compare. Palpate for any inguinal lymph node enlargement and feel for any inguinal hernias. Palpate their groin area and have them bear down or lift their head up. The last assessment technique I would like to discuss is assessing for rebound tenderness. Typically, we do this in the right lower quadrant when we're assessing for something like appendicitis. Normally, there's no pain upon release after pressing. If there is pain present after releasing, consider appendicitis.